Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this dermatology series. Today we're tackling a high-yield dermatologic topic, Tinea Capitis, which is a fungal infection of the scalp that commonly affects children. We'll cover its pathophysiology, clinical features, diagnosis, management, and a few pearls for clinical practice. Stay tuned for clinical questions at the end to reinforce your knowledge. Let's get started. Let's begin with the pathophysiology. Tinea capitis is caused by dermatophyte fungi, primarily Trichophyton and Microsporum species. These fungi invade keratinized tissues like hair and skin. The infection spreads through direct contact with infected humans, animals, or contaminated objects like combs or hats. Patients typically present with one of the following. Number 1, scaly patches with alopecia. These patches may enlarge over time and may exhibit mild erythema. Number 2 is the black dot clinical variant of Tinea capitis. This is characterized by broken hairs at follicular orifices, creating a black dot appearance of the scalp. And number 3 and 4 are less common but still important to be aware of. Number 3 is Kerion, an inflammatory plaque with pustules, crusting, and drainage. It's often tender and can lead to scarring alopecia if untreated. And lastly, Favis, a rare presentation characterized by yellow, cup-shaped crusts, called scutula, to the scalp, which may also lead to permanent scarring alopecia if untreated. Regarding diagnosis, this is primarily clinical, but can be confirmed with a KOH prep. This is a great initial test to identify fungal elements. However, the best test is a fungal culture. This allows for species identification, which can further guide treatment. Now, let's talk about the management. Treatment involves oral antifungal therapy, as topical agents don't adequately penetrate hair follicles. First-line treatment is with an oral antifungal like griseofulvin or terbinafine. It is also important to adjunctively use antifungal shampoos like selenium sulfide or ketoconazole to decrease transmission. And thirdly, follow-up is necessary. It is essential to monitor for clinical improvement and prevent recurrence. On that note, let's discuss prevention, which is critical when managing Tinea capitis. Here are a few strategies to keep in mind to reduce transmission and recurrence. Firstly, avoid sharing personal items. Educate patients and families not to share combs, brushes, hats, or pillowcases. Secondly, treat close contacts. In households where Tinea capitis is present, family members will need to use an antifungal shampoo as well, even if asymptomatic, to prevent acquiring the infection. Thirdly, regarding pet care, zoophilic dermatophytes can spread from pets to humans, so addressing potential fungal infections in household pets is critical. And lastly, environmental cleaning, such as washing and disinfecting shared items and surfaces, is also necessary. By combining these preventative measures with appropriate treatment, we can significantly reduce the risk of recurrence and transmission. Now, here are some clinical pearls. Kerion can be mistaken for a bacterial infection, but requires antifungal, not antibiotic therapy. Secondly, don't skip the fungal culture. While a KOH prep can confirm your diagnosis of a dermatophyte infection, a fungal culture remains the gold standard. It not only confirms the diagnosis, but also identifies the specific dermatophyte species, which can guide treatment decisions, especially in refractory or atypical cases. And lastly, delaying treatment increases the risk of scarring alopecia and further transmission, so it is important to manage appropriately. All right, let's test our knowledge with a couple of clinical questions. Question 1. A 12-year-old boy presents to the clinic with a 2-week history of hair loss and pruritus to his scalp. His mother denies fever, but reports that patient shares combs with siblings. Examination reveals patches of hair loss with scaly skin and black dot appearance. KOH prep shows dermatophyte elements. What is the best next step in management? Is it A, oral terbinafine and antifungal shampoo, B, topical ketoconazole alone, C, oral fluconazole, or D, no treatment is needed and reassure the family? I'll give you a couple of seconds. If you chose A, oral terbinafine and antifungal shampoo, you are correct. This presentation is classic for Tinea Capitis. Oral antifungal therapy like terbinafine is first line, and adjunctively, antifungal shampoos reduce transmission of infection. Now, remember, his family members will also need to use antifungal shampoo for 2 to 4 weeks, even if asymptomatic, to reduce risk of acquiring the infection. Question 2. A 7-year-old boy presents with an itchy rash and scalp hair loss. His mother reports these symptoms started 2 weeks ago. No other family members are affected, and he has no systemic symptoms. Multiple erythematous, round, and scaly patches of hair loss are noted to the scalp. KOH is positive as suspected. Which of the following will be ordered today before patient leaves your office, along with sending a prescription for an oral antifungal? Is it A, fungal culture, B, skin biopsy, C, complete blood count, or D, patch testing? If you chose A, fungal culture, you are correct. A fungal culture is the gold standard for diagnosing Tinea Capitis. It not only confirms the diagnosis, but also identifies the specific dermatophyte species, which can guide your future treatment decisions. Great job! Thank you for joining me for this episode of the Pro PA Podcast. Don't forget to hit subscribe and turn on notifications so you never miss an episode. And remember, this is the Pro PA Podcast, where future pros in medicine are made. See you next time.